Hello everyone. Here is our first lecture on radiation safety and protection. Let's look at the objectives for today. After today's lecture, students will know about natural and medical sources of exposure to ionizing radiation. Students will learn about patient and fetal doses from imaging procedures and the proportion of doses from different modalities. Students will learn about how to monitor and manage patient and fetal dose. Students will learn the meaning of phrases like Diagnostic Reference Levels, Joint Commission Sentinel events, Nuclear Regulatory Commission medical event, patient dose tracking. Finally, students will be able to compare medical exposures to background radiation dose. Natural radiation is everywhere and is called background radiation. There are three main sources of natural background radiation exposure. These are cosmic rays coming from outside the Earth, cosmogenic radionuclides produced in the Earth's atmosphere, and primordial radionuclides already present on Earth. We shall look at each in detail next. Let's look first at cosmic rays. The Earth's outer atmosphere is continually bombarded by cosmic radiation. Cosmic radiation consists of fast-moving particles like high-energy protons that exist in space and originate from various sources including the Sun and other celestial events in the universe. Most primary cosmic radiation collides with our atmosphere before reaching the ground, producing showers of secondary particulate radiations and electromagnetic radiation. Some of these radiations reach the ground and are absorbed by humans. Exposure increases with altitude, approximately doubling every 1500 meters as there is less atmosphere to attenuate the cosmic radiation. Cosmic radiation is also greater at the Earth's magnetic poles than at the equator, as charged particles encountered by the Earth's magnetic field are forced to travel along the Van Allen belts to the North and South Pole. Dwelling structures provide some protection from cosmic radiation. The indoor effective dose rate is approximately 20% lower than outdoors. Cosmogenic radionuclides are the second source of natural background exposure. These are formed when secondary cosmic rays collide with stable atmospheric nuclei like carbon and nitrogen to form radioactive isotopes of these two elements. Although many different cosmogenic radionuclides are produced, they contribute very little to natural background radiation. Most of the effective dose caused by cosmogenic radionuclides is from carbon-14. Radioactive materials present on Earth since its formation are called primordial radionuclides. Natural deposits of uranium, thorium, and potassium are primordial radionuclides that decay naturally and release small amounts of ionizing radiation and other radioactive elements. Population exposure from primordial radionuclides is the result of external radiation exposure, inhalation, and incorporation of radionuclides in the body by ingestion. The single greatest controllable source of radiation exposure in the US population is from medical imaging. Most of this exposure is from X-ray imaging in diagnostic radiology, with a smaller contribution from nuclear medicine. The chart shows that in 2006, the medical use of radiation, not including radiation therapy, produced an average annual effective dose of approximately 3 millisieverts to the population. This 3 millisievert number is about 97% of the total from artificial radiation sources and nearly half of the average annual effective dose from all sources according to the NCRP 2009 report. Compared to CT and nuclear medicine procedures, radiographic and non-interventional fluoroscopy account for approximately 74% of imaging procedures but result in only 11% of the collective effective dose as shown in the table. Although CT and nuclear medicine account for approximately 22% of all medical imaging procedures, they deliver approximately 75% of the collective effective dose. Ionizing radiation is used in a variety of industrial activities and in consumer products. An example is the use of americium-241 in smoke detectors. In the nuclear energy industry, uranium is used as a fuel to generate electricity. As part of this activity, nuclear power plants release regulated amounts of radioactive material into the environment, potentially leading to low levels of exposure to humans. Humans have also been exposed to low levels of radiation from fallout from atomic weapons tests. Here is a table of doses from common imaging procedures as well as a graph of the average background exposures from different locations around the world. According to this chart, the average person in the US receives about 3 millisieverts per year of background radiation dose. Average yearly background radiation dose is about 2.4 millisieverts worldwide. In this table of doses, a chest X-ray of zero point 0.1 millisievert is comparable to a person receiving about 15 days of natural background radiation exposure. Because medical sources are the largest controllable source of radiation exposure, it is important to consider the risk of ionizing radiation to a fetus when imaging female patients of childbearing age. A pregnancy test should be obtained within 72 hours before an examination or procedure if there is a possibility of imparting a dose to an embryo or fetus exceeding 100 millisieverts. This amount of dose is possible for prolonged fluoroscopy-guided procedures and multi-phase diagnostic CT examinations of the abdomen or pelvis. A pregnancy test is not required before proceeding with a medically urgent examination, or if the possibility of pregnancy can be eliminated by factors such as a documented hysterectomy. Pregnancy tests should always be obtained before radiopharmaceutical therapies. Because pregnancy tests can produce false negative results, a test should not preclude questioning the patient regarding the possibility of pregnancy. There are some examinations that can be performed without regard to pregnancy due to the very low dose that an embryo or fetus would potentially receive if the patient were pregnant. These include mammograms and diagnostic X-ray imaging of the head, limbs, or extremities. More detailed guidance regarding a pregnant or possibly pregnant patient is available in the articles and link below. Let's now consider what happens when a potentially pregnant patient is to be imaged with ionizing radiation. In this situation, the radiation dose and potential risks to the fetus should be estimated by a medical physicist and presented to the imaging physician. A risk-benefit analysis should be performed. A few possible steps can be taken to reduce the risk. One possible step is delaying the examination or procedure until after the pregnancy. Also consider alternative examinations or procedures that do not involve ionizing radiation. Another way to reduce risk is to modify the examination to reduce radiation dose to the embryo or fetus. If a lower dose procedure is proposed, care should be taken to ensure that any modifications to reduce radiation dose do not result in a low quality image that will require the examination to be repeated. The imaging physician must obtain informed consent from the patient in all cases. In an emergency, informed consent may not be possible and life-saving measures must take precedence. Let's consider another scenario. Suppose you image a patient with ionizing radiation and later find out the patient was pregnant. What happens then? In this case, fetal age, the radiation dose to the embryo or fetus, and the potential effects on embryo or fetus should be estimated. Dose estimation is commonly performed by a diagnostic medical physicist. The patient is then counseled by a physician. In most cases, the risk to the embryo or fetus is small in comparison with the other risk of gestation. Professional consensus is that there should be no medical intervention with a pregnancy if the estimated dose to fetus or embryo is less than 100 millisieverts. If the dose exceeds 100 millisieverts, decisions will be guided by fetal age and individual circumstances. All X-ray imaging examinations in which the embryo or fetus is far from the area being imaged impart doses less than 100 millisieverts. Also, most X-ray examinations of the abdomen and pelvis, including single-phase diagnostic CT examinations, impart doses less than 100 millisieverts. More detailed guidance regarding the pregnant or possibly pregnant patient is available in the articles provided. Now, let's look at ways to manage patient and fetal radiation doses. This can be done by setting various action levels to trigger quality improvements in the delivery of medical radiation, creating policies, and using tools like dose tracking software. We shall see a few of these in the next few slides. The Diagnostic Reference Level, or DRL, is intended to identify situations where the level of patient's dose or administered activity is unusually high. The DRL is usually the absorbed dose in air or in a tissue equivalent material at the surface of a simple standard phantom or representative patient. If the diagnostic reference level is consistently exceeded, there should be a local review of procedures and equipment to determine whether the protocol has been adequately optimized. Diagnostic reference levels apply to medical exposure, not to occupational and public exposure. Diagnostic reference levels are not a suggested or ideal dose for a particular procedure or an absolute upper limit for dose, but rather represent trigger levels to initiate quality improvement. This table shows current reference levels used by different countries and organizations. The ACR head and body reference levels are shown in oval-shaped circles. While diagnostic reference levels are useful when optimizing protocols, dose reductions should not compromise diagnostic image quality or patient care. Patient care is compromised when a scan using ionizing radiation is repeated because of poor image quality, leading to additional patient dose. The Joint Commission is an organization that offers accreditation, certification, and verification, as well as tools and resources to help healthcare organizations make a difference in the delivery of healthcare. The Joint Commission defines a Sentinel event as a patient safety event that results in death, permanent harm, or severe temporary injury. Detailed information about the Joint Commission policies and procedures can be found at the link below. The relevance of Joint Commission policies to radiation safety pertain to various ionizing radiations. The policy for fluoroscopy is that a sentinel event is any fluoroscopy procedure resulting in permanent tissue injury when clinical and technical optimization were not implemented and/or recognized practice parameters were not followed. For radiation therapy, a sentinel event is any delivery of radiotherapy to the wrong patient, wrong body region, unintended procedure, or greater than 25% above the planned radiotherapy dose. All sentinel events must be reviewed by the healthcare organization and are subject to review by the Joint Commission. The NRC Code of Federal Regulations, Part 10, Section 35.3045, lists the criteria for reporting and notification of a medical event. I have highlighted a few items from the list here. A medical event is when a total dose of administered radionuclide differs from the prescribed dose by 20% or more, the wrong radionuclide is administered by the wrong route to the wrong patient, or the wrong mode of administration is used. If you suspect a medical event, first notify the nuclear medicine physician. The nuclear medicine physician does initial assessment and notifies the RSO if conditions are met. There is a longer list containing more information in the link provided. The next topic has to do with dose monitoring. The tables here show various thresholds for fluoroscopy doses. If a peak skin dose of 3000 mg is estimated after a patient procedure, the patient should be counseled to look for and report any skin reddening or rashes in the location of the procedure. The patient may also be brought in for a skin check by a provider. With current PACS systems available, it is possible to monitor exposures from each procedure and also track doses for each patient using an ID. There are many different products on the market currently. This table from 2020 shows several dose monitoring software. These software allow users to set various thresholds and to estimate peak skin doses and organ doses. Patients' dose can also be tracked over the course of their treatment in each institution. So if a patient has been treated historically, the record can be made available to providers so they know how many times and how much dose the patient has received. Because CT is the largest source of medical exposure, we give it special attention here. A new US technical standard, XR25, was published by the National Electrical Manufacturers Association, or NEMA. CT scanners in compliance with this standard can be configured to inform users when scan settings will result in CTDI or DLP that exceeds pre-assigned values. Compliance scanners allow users, before proceeding with scanning, to confirm or correct settings that might lead to high exposures. Manufacturers may include pre-assigned values in default protocols, but all values can be adjusted by the user. There are two important definitions in the XR25 standard. This AAPM table provides a few recommended CTDI dose levels that imaging departments can use as a starting point to set dose levels on all protocols used for scanning patients. These dose levels are called notification values. These will cause a pop-up to appear when a technologist is about to scan a patient with a protocol that exceeds the notification value. If several scans are planned that will exceed another setting called an alert value, the scanner will prevent the scan from proceeding until the alert is addressed. Alert levels can be initially set at 1000 milligray. The goal of setting notification values and alert values is to detect extreme cases. Passwords must be available to all operators so patient care is not compromised or impacted negatively. Let's finish up with a few questions. First question: which of these is not an example of a medical event? Your choices are: first choice, total dose differs from prescribed dose by plus minus 10%. Second choice, wrong radionuclide is used. Third choice, wrong route of administration. Fourth choice, wrong patient. Fifth choice, wrong mode. The correct answer is the first choice. A medical event requires the prescribed dose to differ by plus minus 20%, not plus minus 10%. Second question. All these are true about cosmic rays except, and your choices are: first choice, extraterrestrial in origin. Second choice, produces secondary radiations after striking Earth's atmosphere. Third choice, range is very wide and depends on altitude. Fourth choice, greater at the poles than equator because of Van Allen belts. Fifth choice, greater indoors than outdoors. The correct answer is E. It is not true that cosmic ray exposure is greater indoors than outdoors. Next question. The largest medical source of ionizing radiation to the US public is from, and your choices are: first choice, nuclear medicine. Second choice, interventional fluoroscopy. Third choice, computed tomography. Fourth choice, ultrasound. The correct answer is computed tomography. Next question. According to figure 21.2, the largest source of natural background radiation is, and your choices are: first choice, cosmic rays. Second choice, radon and thoron. Third choice, internal radionuclides. Fourth choice, terrestrial radionuclides. The correct answer is radon and thoron. This is the last slide. Thank you for watching this presentation.